Is Nicole there? I can't see her. Nicole, are you there?
Not.
No.
Let me just get her for you. I think we're now streaming live as well on YouTube.
Uh-huh. So just so you all know, I don't know whether you've got the same piece of paper as I. The order, the running order is Dr. Wanjeri, Dr. Patel, Dr. Din, and then Director Tole.
Okay.
Tole.
Great.
Is that all right?
Yeah, that's fine.
Okay.
Great.
Yeah. So quick question, could we have our videos off when we do our presentation or whatever works?
I'm not very good at this technically, and I don't have control over it, but I know that there is a facility on Zoom for you to share your screen. And when you do share it, we don't see you. I don't know whether you see yourself.
Yeah, you see a small icon on the left.
I know it can be very disconcerting to see yourself. I did something for one of our virtual literary festivals today.
Yeah.
A festival, which is very big in the UK. And it was very disconcerting. I was part of a panel, and I not only saw them, I saw myself. It's not, you know, I'm quite satisfied with myself, but I don't like seeing, you know what I mean? It's off-putting somehow.
Okay.
But okay. We can ask Nick when he comes on.
Yeah, that's fine. Whatever works, we'll do.
Yeah.
I agree with you, Anjali. I quite prefer not to view myself as well. But anyway, let's hear what's best.
Okay, it's fine.
Yeah, normally I have an icon instead, so yours is
better.
Yeah.
Okay, Paul, I'm just going to start letting people in now, and then I'll give you a cue and we'll be ready to go.
Yeah, before you do, we had a question about when people are sharing documents.
Start letting people in now.
Yeah, hold on a minute. Can you hear me?
We're ready to go.
Yeah, before you do, we had a question about when people are sharing. Can you hear me now? Hold on a minute. Can you hear me?
We're ready to go.
Yeah, before you do, we had a question about when we're getting feedback. Can you hear?
Sorry, Nick, it's from the live stream. The live stream's playing back. Yeah.
Sorry, give it 1 minute and it'll clear.
We had a question about when we're getting feedback. Can you hear?
Sorry, Nick, it's from the live stream. The live stream's playing back. Yeah.
Sorry, give it 1 minute and it'll clear.
Can we talk now?
That better? There we go.
When people are sharing content, can you make it so they don't see themselves? Can you do that?
When they are sharing what? Sorry, when they are.
Dr. Wanjeri, you explain.
So Nick, I just wanted to know, during the interaction, do we just do audios or do we do our videos as well? When you do our presentations, whatever works, we're good with it.
Yeah, I think maintain the video.
Okay, cool.
So that people can see your face. But if you're sharing your screen, then you will be able to then you'll be able to see your face as well. Okay, just bear with me 1 second. I'll be back in 1 second.
Okay.
Patient may be a potential promoter for tumor formation, or certainly the inflammatory milieu may provide the nidus for tumor formation. I did a very interesting study looking at the contralateral.
Hi.
Nicole, you're there. Great. We were wondering.
Yeah.
Hi, Nicole.
Hello.
Hi, Nicole. How are you?
Hi. Nice to see everyone. Hi, Tosin.
Hiya.
Oh, hi, Eunice.
Hello. Hello, Jean. Hello. Have you managed to get your children off your feet?
Only just.
I can.
After that, we will. I might start opening for you.
Oh dear.
For this week, at least, I'll be opening half day, unless something comes up. Somebody calls, I go and see.
Okay, Paul, where did you go?
I'm there from 10:30 to 1 hour.
Good afternoon and welcome. My name is
Definitely.
Lord Boateng, and I'm delighted to be chairing this third in the series of COVID-19 exchange. This is an opportunity for frontline practitioners, policymakers, activists to come together to look at the situation in which we find ourselves on the continent of Africa as we combat the virus, and to do so in a way that enables us all to share good practice, to come forward with practical solutions to bring about the improved outcomes for patients and for community alike that we all seek. We come together under the auspices of Medicus and BOBAB, and I'll be asking Nick State for BOBAB and Nicole Coyote for Medicus to talk to us in a moment, but we come together under their auspices in order to make a difference. It's a conversation. So you will hear 4 speakers. They're all going to be very disciplined in terms of time. And there'll be an opportunity for you at the end of each to ask a couple of questions, and then together for us to have a conversation. So without further ado, let's get underway. And I'm going to ask Nick State to introduce BOBAB, who are co-sponsors of COVID-19 Exchange. Over to you, Nick.
Thank you, Paul. And thank you everyone for taking the time to be here today. As a very, very quick introduction, as Paul mentioned, for those of you who don't know me, my name is Nick State. I'm the CEO of BOBAB, and we're an event streaming and peer-to-peer networking platform dedicated to connecting science, tech, business professionals working in Africa, but also working for Africa around the world. We exist with a simple but ambitious purpose to accelerate science, tech and innovation happening in and for Africa. And we do that by working with partners like Medixus, to host events like this, where we try and make it easy for experts like all of those on the webinar today to come together, to connect, to explore challenges, and crucially to promote innovative solutions and enhance collaboration around those solutions. From BOBAB's perspective, we're absolutely delighted to be co-producing this series with Medixus, who I know are doing a tremendous amount of good work on the continent, particularly in Kenya, and have proven to be a really valuable portal for lots of medics and doctors on the continent seeking information and advice and insight, particularly around COVID-19 and beyond. In terms of today's focus, we're really interested in exploring the challenges, but also the opportunities that COVID-19 and particularly the lockdown measures imposed by many governments in Africa and around the world have presented to healthcare professionals. And I hope we'll also be highlighting some of the innovative steps that some of our panelists have been taking to ensure continuity of care. So yes, another really interesting discussion in the offing, and thanks again to everyone for joining.
Thank you, Nick. Nicole Coyote.
Thank you. Hi, everybody, and thank you again for joining us. Some familiar faces from the previous webinar, so good to see your names, if not your faces. So as Nick mentioned, I'm Nicole Kaide. I'm the CEO and founder of Medixus. We're a knowledge sharing platform for medics across the continent and more broadly globally. And we help improve communication both within facilities and between facilities. So this particular webinar is, all of them have been very important to us, but this particular one touches quite close to the heart of what we are trying to do with helping facilities to maintain business as usual, with managing virtual patient lists, with collaborating with peers that maybe aren't able to be in the hospital physically to give a second opinion on a patient case. So it really touches at the heart of what we try and do at Medixus. And I know we've got a really great lineup of speakers that I'm very excited about and hope you all are too. As a quick housekeeping thing that I think Paul's probably already said, but to reiterate, please make sure that if you're not speaking, you're on mute, because we're going to try and have this week without any technical difficulties. Although I said that, now we're going to have every single technical difficulty. So good luck.
Thank you very much indeed for that, Nicole. And I can't stress sufficiently the importance of putting yourself on mute if you're not speaking. But the context is a significant one, and we're very fortunate to have the speakers we have. The significance of the context is very much one not simply of seeking to establish how we can best meet the needs of patients, of carers, and medical practitioners now, but how, in the context that Africa faces, of pressure on resources, on having to cope with issues around sparsity, rurality, how we utilize what we learn now to help us build for the future. This is a crisis, but it's also an opportunity. Africa has shown in the past, and Kenya actually in particular, in the field of banking and telecommunications, that it's possible that out of Africa comes something new that is directly relevant to the needs of the global community. Because the issues that you are facing are issues that are also faced globally. And I think the important thing is to recognize the contribution that Africa has to make, not just to African solutions, vital though that is, because the best solutions are ones that are rooted in the communities we know best and that are reflective of Africa's needs, but also the contribution that Africa can make globally in terms of better meeting the needs that come from distance and remoteness, the needs of ensuring continuity of care. So without further ado, I'm going to turn to our first speaker, Dr. Millicent Losi Wanjeri, who brings vast experience, both as the Director and Content Manager at Toto Health Kenya Limited, as a medical officer within the COVID response team of the Ministry of Health in Kenya, but she brings the experience of 6 years of digital health innovation with a particular focus on mobile technology in influencing health-seeking behavior with particular reference to maternal and child health. So without further ado, over to you, Dr. Wanjeri.
Thank you so much, Paul. I'm really grateful for this opportunity. Let me share my screen as I start my presentation. First things first, as you've heard, my name is Dr. Millicent Wanjeri. I'm a medical officer with COVID-19 response right now under the Ministry of Health in Kenya. Apart from that, the Director and Content Manager at Toto Health Kenya, and I'm grateful for that role as well. So today I want to speak about the role of digital health in strengthening of health systems during the COVID-19 pandemic. And what I'll start is we need to understand what is happening. And first things first, we know that there's been a paradigm shift in our focus in the last few weeks, particularly a focus from our non-communicable diseases and all the other diseases that we see And WHO has significantly reported that nearly 40% of the non-communicable diseases that we have, we are seeing patients having increased severity of diseases for one reason or another. And the most common ones that we see are diabetes, cardiovascular disease, our cancers, and all the other, and mental health disorders as well. And it's important to note that these very same conditions are contributing significantly to the number of deaths that we're having as a result of COVID-19. And we all know that globally, we are trying to achieve universal health coverage, but I think this year has taken us back significantly when it comes to what we're trying to do. So let's look at the various building blocks of our health systems and what COVID has done to us. So we know, like for the health workforce, myself, doctors, nurses, and all cadres, we're seeing significant number of healthcare workers dying as a result of COVID-19. This is because of the increased occupational hazards. When we look at healthcare financing, we see that many people are out of work. So our household incomes are reduced significantly. And very soon we'll see, particularly for those who pay monthly premiums for insurance, they might not afford this, so they will be paying out of pocket. What we will see is that the financial risk protection for our individual households is going to reduce significantly, and more people will spend money trying to access healthcare. So as access to essential medicine, we have seen the curfews and the lockdown reduce movement. And we're also seeing a reduction in service delivery, particularly for those who need essential medicine. I will make reference to those with non-communicable diseases. Our leadership and governance as well has been focused on COVID-19. However, previously we were all trying to focus on universal health coverage, improving healthcare access, but now we're all focusing on COVID-19. Service delivery, I mean, in Kenya, we are seeing most of our outpatient facilities closing down. They used to provide core foundation to treat basic diseases, primary health care. But right now we are seeing, one, the need for social distancing. A few people are getting to hospital. Worse off, the stigma associated with COVID-19 has really compromised patient care. So as I had alluded to, this is the workflow that WHO has recommended in terms of our systems building blocks, what we need to do, and our anticipated outcomes. So we need to improve health, we need to improve responsiveness, we need to improve social and financial risk protection and efficiency. And we can all attest to the fact that COVID has brought all this to a standstill. We are not able to achieve all our outcomes, particularly in the recent months. Yeah. So where are the needs? So our healthcare systems are straining day by day. As an innovator, I know my primary role and my responsibility to society is to solve the most pressing needs, particularly at such a time. So when it comes to access to healthcare services, particularly for obstetric cases and acute emergencies for those with chronic illnesses, we need to figure out how do we help patients access services. We need to just figure out how patients, particularly those with chronic illnesses, will access their medication and supplies. Emergency evacuation right now, particularly for road traffic accidents and trauma victims, is now becoming a very big problem, particularly in low resource setups and countries like ourselves. In Kenya, we're having a very big challenge moving patients from point A to B, particularly during the lockdowns. We need investigation and diagnosis capabilities, particularly point of care, whereby even a patient can self-diagnose when they're well informed. And last but not least, we need home care services. In a country like Kenya, where we have deficits, even in terms of our resources, we need to start evolving to a point where we embrace home care services. So, so far, there are certain things that have been done. As Paul had mentioned, in Kenya, we have made significant strides. He had mentioned telemedicine and banking sector, but even in the healthcare space, we are doing relatively well. Medixus has come to really help us in facilitating handing over of patients, particularly after emergency services, whereby we can easily, healthcare worker to healthcare worker, communicate. Total health services, we are giving healthcare information. We are trying to inform behavior change so that our mothers can be aware. We are really focusing on primary prevention. My Dawa is another platform whereby they allow patients to order and to receive medication as per their prescriptions at home. So it's a delivery service that helps patients access essential medication. Ilara Health is also starting up in the country, and they've created point of care devices that allow all cadres of physicians to do their very own diagnostics. Nadia Kenya is an upcoming telemedicine platform which allows online consultations between doctors and patients. So these are examples of what is being done. But what is being done is just a drop in the ocean. We need to do so much more to make sure that even with the challenges we have, our patients get the very best. So as innovators, as everybody listening, we need to come up with solutions to strengthen our healthcare system. Yeah, we need to come up with platforms. We need to come up with technology, and it's not just limited to technology to sort out healthcare financing. How will people be able to afford healthcare? Home care services. How will people get their services at home? We need to start screening for disease. Is there a better way to screen for COVID? Is there a better way to screen for other diseases that might actually kill people more than COVID is killing people, particularly our children in the coming days? We need to figure out counseling and psychosocial support because we are going to see a lot of depression, a lot of bipolar, a lot of anxiety disorders, particularly post-COVID. And again, alluding to health financing and healthcare access, not every one of these people will get to us. So what can we do? As a result of this, again, we need to enhance our patient data management, because if we knew how many patients were high-risk patients for COVID, would we have taken them as a special population for us to care for? So last but not least, we need to figure out how to do our healthcare and human resource management in a better way, because we have lost so many. Are there different ways we can actually come into place, fill in this gap of the people we have lost? We cannot replace them. But is it something that we can do to protect our healthcare workers, use technology in ways that we're going to protect our healthcare workers? But that said, I'd like to say thank you. There is a lot of opportunity. There is a space to be filled. There is a lot that we can anticipate post-COVID, particularly in trying to achieve UHC. And I want to pray and I want to believe that each one of us here would come up with a solution. Thank you.
Amen to that, Dr. Wanjeri. Thank you very much indeed for that insightful and comprehensive presentation. We've got an opportunity now for a couple of questions. Anything coming through on the chat? You've got your chat in front of you. Do use it, and we can ask Dr. Wanjeri to respond. So I'm inviting people to contribute through chat. Nicole, I know, is keeping an eye on questions as they come through. Nicole, have you any?
Sorry, I'm on mute. Not any questions on my side that I can see in the chat yet.
Good. I've had none yet on mine, so we'll move straight on and we'll.
Not any.
Have we got a question coming through?
No, sorry, that was the playback. After all my talk about technical difficulties, I've just caused a technical difficulty.
That's always the way. That'll serve you right, Nicole. I've just got one. Which I'd be quite keen on you to expand upon. It's about how we use this technology to better protect our frontline healthcare workers. If you've got any example about how that is working out in a Kenyan context, because I know it's a big issue, not just in Africa, but globally, and we're finding a disproportionate impact on healthcare workers, particularly as it happens, Black and African, Asian healthcare workers in a setting outside the continent. Have you got any tips, any ideas about how technology can help in that?
Yes, okay. Currently, I'm aware of a project by Project Carroll Academy of Engineering, where they want to they're creating reusable N95 masks. We know there's a shortage of PPE globally. And what would happen with these N95 masks is that the healthcare workers are even able to actually sanitize and resanitize, and you can even use one over a period of 2 months. No, sorry, of 2 weeks, sorry. So that is a way of coming up with low-cost PPE that we can use to protect our healthcare workers. Number two, to limit social interactions, our telemedicine platforms are also kicking in. They're not quite, we haven't scaled much in the country, yes? But when you look at risk protection, in that we minimize patient interaction. So if I can actually do an online consultation, especially for a low risk patient who does not necessarily need to come to a hospital, it's a very good way to actually protect people, do the social distancing, and make it minimal exposure. Yeah.
Thank you very much indeed for that.
We have had one question from the chat from Anthony, who has asked what's the situation regarding hospital capacity, which may be covered by our next speakers, but also feel free to answer if you have one.
Any brief comment on that, Dr. Wanjeri, hospital capacity?
I know significant reduction in our inpatient admissions, but I believe the other two speakers would actually allude to the same. Yeah, so I'll hand it over to my colleagues.
Thank you very much indeed for that, Dr. Wanjeri. If we can now turn to our second speaker, Dr. Patel, Dr. Kunal Patel, who is a travel medicine physician, an academic and global health specialist who lectures internationally on the themes of global health and the interface between technology, health education, and training. He has been instrumental in primary care system strengthening, in advocating for greater health education knowledge globally. So we're really glad to have you with us today. Dr. Patel, over to you.
Hi, Paul. Thanks very much for that. And just to promise you, I have a timer here, so I'm going to keep on track. So hopefully you won't hear the alarm when it goes off. But thanks, everyone. I'm not going to present any slides. As Paul introduced me there, I work as a physician, but also I work on the clinical education space where we utilize technology and innovation where we can. And we are training health workers ranging from nurses to doctors across the globe. What's interesting, and I'm going to follow on from Dr. Millicent there, is that education and training, if you're to look at it from a purely remote educational training perspective, every issue around COVID-19, every healthcare issue across the globe can somewhat be fixed by better education and training. And it goes beyond healthcare, of course, as well with that. And so what I'm going to touch on is just some points about what's currently happening. And then I'll round that off with some a concept which we're now trying to see being implemented in numerous countries, but hopefully more as the pandemic sadly is spreading, but also as we try to change at a rapid pace. So if anyone can read Portuguese, you can always, the national papers, they published this list which we put together of what things are going to change during the pandemic, but also what's importantly going to change afterwards. And that's going to impact on how we're going to remotely train healthcare workers, university students, medical students, nursing students, and more into certain topics that are absolutely needed right now. And interestingly, it's not necessarily COVID-19 specific. It's, as Dr. Millicent said there, it's other topics and other vulnerabilities that we have and are facing currently. So firstly, one of the most important ones is that we're now seeing an increased awareness of healthcare vulnerabilities. And what we mean by that is the health worker vulnerabilities, and specifically the increased spike in mental health amongst health workers, how we're going to address them during the pandemic. And we're now seeing a change in how that's happening. For example, established publishers such as Taylor and Francis are producing free resources that are remotely available around mental health, specifically to address health workers and the capacity that needs to be maintained as more and more health workers become vulnerable. There's an increased focus on health systems. The vulnerabilities of systems that are predominantly private or do not provide universal health coverage have been exposed. And the countries that interestingly have more of a private system have actually been shown to be more vulnerable. So more training needs to occur in terms of how policy and how practice can be put in place to ensure universality is maintained. But interestingly, we also have to counter, as educationists, an increase in public distrust. You know, the quarantines and lockdowns, they're changing policies that are happening all the time. They're happening overnight. And on top of that, when you get, for example, a good example is the Democratic Republic of the Congo. It's had a huge measles outbreak for the last while. And the WHO, and sadly, a large anti-vaccine movement at the same time. But on top of that, we've also had the WHO during the COVID-19 pandemic ask that all national vaccination programs stop. So what's happening? Distrust is growing, and at the same time, cases are going up for vaccine-preventable diseases. So we need to train the public as well as the healthcare workers in DRC as to how to counter that. And something like this, as a Zoom call, is a very good way of what we call a virtual community of practice where that can occur. if the technology can support it. And that's a big if. We've also got to consider the region-specific issues that lend themselves to an increase for more remote work and remote learning. And a good example of that is, it's very interesting now that the WHO has declared that how COVID is going to affect Africa, it's going to be different to any other continent, and they're correct. And what's interesting is when you look at the numbers, and if you looked at the numbers from last Friday, there were over 99,400 cases recorded on the continent. But interestingly, the countries, excluding South Africa, that have been hit probably the hardest are the ones where educational systems and infrastructure have been disrupted, as well as healthcare infrastructure and systems, due to political unrest and civil war. And they're namely for example, in the Emro region, for example, Egypt, Libya, Somalia, Sudan, and so as an educationist, again, we're not only tackling a breakdown in the healthcare system, we're having to tackle a breakdown in the educational system as well. And it's now shown that numbers in Africa, that we've got almost 300 million students who have suddenly lost the capacity to continue their training. And that extends to almost over 1 billion worldwide. So you can look at Africa as a continent, but we have to look at it also specifically from country to country. And that then leads more towards healthcare assessment and healthcare training assessment or university assessment. And we now know that universities cannot just open and maintain large populations. So how do we shift all that working remotely? There are new technologies that can help with invigilation of exams, but questions need to still be asked as to what about these healthcare students that have lost study time? How can we bring them back into the training world rapidly without compromising their ability to manage patients or clinical care? Then after that, we've also got to think, how does remote working, now is the opportunity to help improve collaboration and what we call interprofessional care. The pandemic has forced many collaborations to arise rapidly. For example, as I said, the Zoom room is one example. BOBAB and Medixus are platforms that do exactly that as well. But at the same time, it's got to be interprofessional. You just can't be in the virtual space. You have to be learning from each other. You have to be collaborating so that the outcomes can improve, both at the hospital level, at the primary care level as well. And then Dr. Melissa touched on innovation. Innovation in remote learning doesn't necessarily mean new technology. If we looked at the SARS epidemic back in the day, there was an increased use of remote online problem-based accelerated learning in China, and that's been maintained, but the technology hasn't changed. Can we maintain that rate of innovation in a similar fashion to SARS as we can with COVID-19? And then at the same time, can we then move from large group to small group learning? I mean, we've cancelled classes. We can no longer have lecture theatres that have over 150 people in them. So we have to think about interactive learning groups. And that's really important. And they may have to be small, but so be it. And how can be controlled using current technologies? And those current technologies don't necessarily have to be new or something. You don't have to be obsessed with trying to find a new app, for example. You could be using Skype, you could be using WhatsApp, you could be using Zoom, you could even be using telephone. And interestingly, when you think about certain countries, how they're dealing with remote education, you look at Bhutan, Chile, and China, they're offering e-learning platforms that are very basic. Countries in Africa, such as Ethiopia, have identified areas of remote learning need, but with very little implementation. Yet Kenya has provided guidelines via their Ministry of Education on enhanced teaching. And that enhanced teaching hasn't necessarily come from mobile or from a new technology. Radio has been used heavily. But that can extend all the way to the loon balloons that Google provide. Previously, I mentioned Libya. They've actually made TV viewing mandatory for students. So there's hours during the day on television where you are by law having to watch certain programs that you can continue your learning. And interestingly, the Rwandan Education Board has struck an agreement to waive all internet fees via the main providers. So again, education can be provided remotely. So these are all concepts and ideas, some are in practice, some are not. But the model to think about is that, and this is coming to the model that we as educationists are seeing in the remote world, everyone has to be in this one sphere. And this one sphere contains the students and the health workers in the middle. But around it, you will have the patients, you will have the technology infrastructure, the hospital infrastructure, and then you will also have the educators themselves. And they all feed into the students and the health workers, but they also pick up from each other. For example, the patient should impact or input into the training, as should the trainers themselves. But then within that bubble, the only thing that should influence that bubble is national and international scientific evidence. And therefore you create this whole dynamic learning environment, which is very different to our traditional remote learning environments, because now the frontline health worker has to train while on the front line. They can't just go to a lecture theatre and maintain their COVID-19 training. They have to do it while they're in that space. The training has to be what we call dynamic remote learning. And so forth, it's no longer the clinical setting, but widened to include the online learning space. And that involves those elements. But ultimately, and just to finish, you've got to think about contextualized, cost-effective remote learning delivery channel, which can outlive COVID-19, because COVID-19 is not going to be the biggest issue this world faces after the pandemic. It's raising cancer cases, it's raising diabetic cases, raising mental health cases. So if we have broader support for online learning, we could easily tackle those very, very rapidly using current technologies. And certain things like that could include zero rating smartphones and providing subsidized Wi-Fi in low resource environments. Very simple policy measures that can come into place. But my time is now up, but I hope I've provided some concepts there that are addressable, can be addressed universally across the globe and can be taken into the way you want to design your remote learning environment, certainly now, but also after the pandemic.
Thank you very much indeed for that, Dr. Patel, and thank you for exposing some of the opportunities that this virtual community of practice can see taken up, not least in terms of interdisciplinary working, the importance of an approach that is centered on the learner, on the clinician, but at the same time recognizes the input of patient and community into all of that, and the need to be relevant and specific to the context in which that healthcare is being delivered, not least the impact in Africa of those external issues around conflict, around pressure on resources, around poverty and hunger, nutrition, that have a direct bearing on not only COVID-19, but on a whole heap of other overlaying and underlying conditions. So thank you for that. Now, I wonder if we have any, we've got some questions coming up, a lot of very positive comments. One thing I know that's very much on people's minds, and Nicole, you'll be coming forward with some questions, I know, through your looking at the chat, but I can see, again, it's about frontline workers and their access to support, not just in terms of PPE, but how you address their fearfulness, how you address their issues around insurance, how you educate hospital administrators in the HR implications of having so many frontline workers who are exposed to danger now that they didn't actually necessarily sign up to when they became frontline health workers. Any insights into that, Dr. Patel?
Yes, I think it extends from that model of a dynamic training space, and that doesn't necessarily, because as you work as a frontline health worker, you're within a training space as it is. We're now seeing that we may need to think about how we've talked for years in the education space about compulsory training slots, like space to learn during your 9 to 5, during your 5 days a week, or in this case, any time of the day if you're a frontline health worker. Frontline health workers need to be given compulsory time slots to downtime, for counseling, and for training. And that currently is something we've talked about for years, but it's still not implemented. And that has to come at the highest level, at the policy level, from a hospital infrastructure and primary care level, to say that actually all of our workers during their shifts need to be given maybe 20 minutes for them to catch up in terms of their training and learning and downtime, and even counseling when needs be. because as you said, it's not necessarily the COVID-19 or the PPE risks that are at play here. And so whether that will come in, we don't know, but that's certainly what we're advocating for.
Thank you very much, and very important that policy makers and legislators hear that message. Nicole, have you got anything else coming through on the line?
Yes,
If
we've
I
got,
may, sorry,
yeah.
go on.
oh, we've
Nick?
got a question from Lois, for Lois, sorry, from Esther, but maybe we can do that one at the end.
Yeah, we're going to hold that one.
Yes, and then we've got one from Anthony, which is, I guess, more of a comment that he would be pleased to partner with Dr. Patel as he's working on a project with the University of Nottingham and Derby on international healthcare training. So yeah.
Right, very an enterprising intervention. Good.
Yeah.
Unless there's anything further, I'm going to move straight now into Dr. Din's presentation. Dr. Tausif Din, we're delighted to have you, brings a wealth of experience over 16 years, 9 years of which were in healthcare management at the MP Shah Hospital, for which she is a very vocal advocate, as I know from my own experience. She currently holds the position of CEO there, and under her leadership, the hospital has delivered a number of projects, including establishing a new pediatric unit, launching a bariatric surgery program, and setting up a diabetes care center. Diabetes is so important at this time because we know that that has contributed to a number of deaths as a result of the virus. She's a fellow of the ACCA in the UK, and we're just thrilled to have you with us. Dr. Din.
Thank you, Paul. And the invitation is open to you to visit our hospital anytime. And a very good afternoon to all the panelists and to all the participants for making in time to tune into this webinar. And thank you, Jean, particularly for assisting with the entire technical matters that came. So I'll immediately get into the presentation, and I will be talking about a few things. And I think basically just to start by telling you a little bit about our hospital and what the current status in Kenya is. I think many of us are not aware of all the hazards that healthcare workers face. So I'll be talking slightly about that in brief though. What are we really doing about them, and what kind of support and motivation is our hospital really rendering towards our staff? Ampisha Hospital is one of the top leading private hospitals in the country. We are a 210-bed hospital, and we have a workforce of about 1,000 staff, out of which 70% are clinical health care workers. Our key priority since COVID-19, the first case was identified on the 13th of March this year. And our key priority has always been healthy, safe, and decent working conditions of all healthcare workers amidst this COVID-19 pandemic. The slide on my right is no new slide to the Kenyans who have logged in. And when my friends and my family call me from the UK and other parts of the world, they say, "How many deaths do you have in Kenya?" And I say, "About 50. It's like, "Only?" And it's a bit of an insensitive remark, but I would say that for us, losing even one life, we've really tried our best. It has gone into many hours of dedicated services and many risks that we have faced. So 52 may be a small number, but it's a very big number for us as a country. We've so far got 1,286 cases, and globally, I think we've got 5.4 confirmed cases, and deaths are about 345,000. These statistics are as at last night. So what are these hazards that healthcare workers really face? I mean, in the Kenyan setup here. So there is the pathogen exposure. We have long working hours here in Kenya. We have been exposed by some government regulations on night curfews, which means we cannot step out of the house from 7 p.m. up until 5 a.m. in the morning, which means that we have to stagger our shifts. We have to work longer hours, sometimes even 14 hours. And definitely that is a lot of fatigue on an individual who has many things that are going on on their minds. We have psychological distress and occupational burnout. We have stigma, where these staff, when they go back home and they're being asked that, oh, so you work in a hospital, so how many COVID patients are you treating? Or perhaps they are not being talked to with love and comfort, and they have psychological issues, and of course the risk of community transmissions. And I think one risk that we really are not really bringing it out in the open is the financial risks that these healthcare workers face, because here in Kenya, and MP Shah Hospital is not new to this, but many hospitals have experienced a sudden downfall in numbers. Suddenly the occupancy levels have fallen, people are scared to come into hospitals, and they're preferring to go into outpatient centers. So what are we really going to do about all this? We're going to implement the appropriate combinations of engineering and administrative controls. We're going to promote safe work practices. We're going to have PPEs to prevent worker exposures. Here in Kenya, we've had a very major shortage of PPEs because we do not have manufacturing plants that are readily available, but now the government is working towards this, and this is definitely a ray of hope for all us healthcare workers. We are very strong and key on training and education, especially for infection prevention and control. And key attention is being paid to psychosocial support. So one of the first things that we did as a hospital is to be able to set up an acute respiratory infection tent. This was to be able to keep all the crowd away from the main facility. Our facility expands to about 3 acres on whole, and it's quite a big complex. So based on this, we set up a tent that was away from the main facility of the hospital, and we implemented a cardinal questionnaire. This cardinal questionnaire would ask someone, have you been in contact with a COVID positive patient, or do you have a travel history in a country that has COVID positive patients, etc. And that was able to help us to filter out these patients. And I think this tent also helped us the prompt identification and isolation of potentially infectious individuals. And also we tried to restrict personnel entering into isolation areas. We then went and launched many safe campaigns, not only for our staff, but also the relatives who are visiting the patients and the ancillary and support staff who are visiting the hospital. And we tried to advocate this through our doctors, where we told them, we stay at work for you, so you stay at home for us. And we tried to limit the number of visitors coming into the main hospital with a lot of social distancing mechanisms that were put across the hospital. Further, we introduced a 24 hours helpline, and this was not only to give support to the staff and to give support to the patients, but it was more of a Tele-Triaging helpline, and it is still active to be able to filter out patients who really need to come to the hospital. If you really don't need to come to the hospital, then we actually divert these patients to our outpatient centers. We also went ahead. I think staff were generally very scared. There's like, this is something new for us. What do we do about it? So we have a new medical center as part of the main complex of the hospital, and it is still under construction, but luckily about 3 to 4 floors of this unit are actually complete. So what we did is we did not want to mix COVID positive patients with our well patients for other comorbids in the main facility. So we introduced additional bed capacity. We now have a dedicated team of nurses and doctors looking after patients in this unit. It's independent of the main hospital. And one of the key things that we did was the identification of workers who may be at increased susceptibility for COVID-19. And we adjusted their responsibilities. For example, staff who are over 60 years, we were not deploying them in this unit. Our staff who are pregnant, for example, we were not deploying them in this unit. Furthermore, we are very key on training, education, and I think what we lacked as a hospital, we had the PPE, but the effective use of this PPE was to be trained on how to don, how to doff, how long can you use an N95 mask for? We develop protocols. What do you do with an admission for a COVID positive patient? And I think the training and education try to reduce the fears that the staff had. And I think with the training, they had more confidence to be able to handle these patients. And if you're scared, you end up making more mistakes. But if you're trained, you're educated, you know what you're supposed to do, you're following the protocols to the T. And we did a lot of online CMEs. The picture that you see on your screens is some of our doctors educating all our patients and our nurses. We then ran an entire campaign of infection prevention and control training where everyone felt that sanitizers was the only way to wash hands. But I think we advocated the constant use of soap and water, and the staff felt that you don't necessarily need a sanitizer to be able to remain clean. And we also tried to run campaigns on phones, that how often do we wipe our phones? We try to divert a lot of traffic from our main hospital. As I mentioned earlier, is that many patients and many people who are sick, like for example, with the diabetes, having issues with their health, were actually very scared to come into the main complex. And sometimes we'd even receive calls to us, do you have COVID positive patients? Otherwise, I wouldn't want to come into the main hospital. And that was quite disheartening for us, but we do have a satellite clinic, which is located in a very busy mall, and that is where we were actually sending our patients so that they could have access to healthcare. We have specialty clinics, a pharmacy, a lab, a casualty, dental and ophthalmology units in this particular facility. It was really nothing new for us, but we decided to even follow suit of many international and local companies. We've introduced telemedicine portals, pharmacy on wheels, and we even have a 24-hour ambulance. As mentioned, financial risks, I think these are really key. Are we really giving our staff the job security that they need? So we said, yes, we are not making anyone redundant here, and we're not sending anyone home, and we were able to provide them the job security. We are able to give them staff medical insurance, which includes their dependents, and we also ensured adequate staffing levels. This is a very important slide for us as a hospital, because a lot of time and a lot of labor has gone into organizing these mental health sessions. Psychosocial support teams and mental health clinics have been on standby. It's not easy to tell a nurse that you have been now allocated to work in the COVID ward, or a doctor to be allocated. So I think this kind of social support team was building a great infrastructure for us and continues to do that. We are very strong believers of the importance of spiritual nourishment, trust in God, and involving staff in decision-making. We were not just slapping decisions on staff, but we were involving them in these key decision-making processes, adequate provision of PPEs right from the start up until the end. We provided staff in-house accommodation. Symptomatic staff were immediately sent on mandatory quarantine with stay home if sick policy. And finally, non-healthcare workers. I think a lot of importance is being given to healthcare workers, but within part of a big hospital with 1,000 staff, we also have a staff who are working in an administrative capacity who needed training, who needed guidance, and they needed support. The safety of our healthcare workers is extremely important, and we value our frontline staff. And remember that all those healthcare workers who are tuned in this afternoon, you are the hope of many Kenyans here. Conclusions are that the main accomplishment for us as a hospital, as there's none of our staff are infected with COVID-19, none of them are positive. We have retained all our workforce, and we've created a conducive safety and health culture. We are ready, we are fit, we are energized, and we are ready to receive increased numbers of COVID-19. Finally, I take this opportunity to thank the board and management of the hospital, the entire COVID-19 task force, Medixus, Bob, the panelists, the participants. God bless you all, and thank you for giving me the opportunity.
Thank you very much indeed for that presentation, Dr. Din. Thank you for the necessary focus you brought on managing financial risk for our teams. That's very often overlooked, and it's hugely important. And interestingly enough, it came up and has come up from one of our participants on the chat line as a particular issue here in the UK. So thank you for that. Thank you also for your message about making sure that we think of the whole staff team. The hospitals are not just frontline clinicians. They are cleaners, they're administrators, they're people who work in reception. Thank you very much for reminding us of that. And I love the hashtag that I noticed on your presentation, spread calm, not chaos. That's a very, very good one, and we're grateful to you for that. Now, any questions coming up?
We've
Good.
got one from Kunal, who says, for Dr. Din, do you think all of these rapidly developed procedures will be maintained and used after the pandemic?
Thank you very much.
Absolutely, yeah.
Indeed.
Should I answer the question?
Yes, do by all means.
Okay, thank you for this question. And certainly, I think COVID is not something that is going to come and go. It's going to stay with us for a very long time, and it should be built into our medical protocols, and we should have robust systems to be able to handle this at any moment in time. And we don't know what the process is. I mean, every day here in Kenya, sometimes we test 21 positive cases, 71. We should be ready. And the good things and the good practices that we have learned from the implementation should definitely continue. Why not? Yes.
That's great, thank you. And I think we had one more question for you, Dr. Din, which was quite a specific one. Do you have any technology to disinfect and to screen? And then you've also had a comment to say that it was very impressive speech, so thank you.
Thank you. Thank you, Christine, for your very great remark. It's not every day amidst COVID crisis that you get positive remarks. It's quite a stressful situation that we all are in, and being at the helm of a healthcare institution, it definitely gets difficult. Zola, thanks for your question. We did sample out quite a number of disinfectant zones. Unfortunately, the chemicals that are being used for these disinfection tents have been proven to have allergic reactions, not only on adult patients, but also pediatric patients. So as much as we do have a plan, we have not implemented it because they can be quite irritating to the eyes. So that is one of the reasons, even though the water and the disinfectant pass through millimeters and it's basically just a very light spray, they tend to give irritation to patients and especially children. So we haven't really done that, but our pre-screening tent is able to use infrared thermometers and of course the cardinal questions that are able to filter patients into the main facility.
Thank you very much indeed for that. And I think it was helpful too, that slide of yours that showed, you know, you can actually disinfect your phone with an ordinary wipe, you know, just that chamomile wipe slide you had. Very sensible, very practical, low tech advice, but something that makes a difference. So thank you for that. If we can now move on to our final speaker before we move out into a wider conversation, a director of quality at the Aga Khan Hospital in Nairobi. Eunice Toll brings 15 years experience of clinical services management. She's worked as a program administrator for surgery and accident and emergency. She's worked in the theater as an acting manager. She's worked right across the field as a consultant, in consultant clinics and in family medicine at the Aga Khan Hospital. So a broad and deep experience, and we're very glad to have you with us, Director. So over to you.
Thank you very much. As I share my screen, I also want to thank Jean and the team, Nicole, and thank you for this opportunity. And to Dr. Dean, I think you peeped into my slides or I peeped into yours. There'll be a little bit of repetition. So, but that's where we are. So yeah, when this whole COVID-19 aspect started, I think as individuals and as healthcare workers, to be specific, what came to our mind was what we could see, what we heard, what was already developing in the other countries and in other continents. And so as Kenya, coming to Kenya, we were a little bit of, if that's what's gonna happen, we are not ready. So we got into this already feeling a little bit of pressure, emotion, and everything that comes with it. But we knew at the same time, we had to have business continuation and it needed to be in an unusual way. What we didn't know is what way was that going to be. And so as a team, what we decided is we're gonna have to do this. It wasn't an option. It was a must do, as my slides say. And immediately with the teams together, we kept on talking to each other and saying how we're going to do this. So this slide tells you how we immediately thought was the best way. Perhaps it wasn't the best, but we have learned from it all along. But we knew we had to stay safe, we had to be productive, and we knew we had to do it together. So we got teams together, which was a task force committee and an operational committee. Later on, as you will see in the slides, we have had a sub committee that is clinical and psychosocial. Bearing in mind that the first two were started off before we ever received our first patient. So what we did with the task force is that it has most of the senior leaders and of course the CEO. And with that, it gave strategic direction and immediately gave us hope and gave us an opportunity to do what we know how to do best. Soon the task force began to endorse guidelines proposed. Soon they brought up, and I don't have the pictures, but before we could even move forward, before we even had our first patients, we reduced the entries to our hospital. Our hospital has had 7 entries, and actually after this, we probably will never open them, but it was a blessing. We immediately got permission to close down 3, purely because we were starting off the thermal screening. The sample collection unit in the emergency department started. Because of the standard we had, the negative pressure facilities were already available, but it was more enhancing the use of that room and the people involved, where it required a lot of education and everything that comes with it. I just want to add now, within a short time after that, we've enhanced the drive-through available at the ED area. So the negative pressure room is not necessarily the place now that we use for that. PPE was an acronym that we'd used throughout my standards and quality and my audits. And every time I went to sessions, no offense to the doctors, they'd always ask, what's PPE? That word, that acronym was never known to everyone. Now, even the little children out there can actually pronounce it, and not only that, know what it means. That said, this is a learning and it is great. The use of PPE suddenly became the norm. And well, I know that Kenya or Africa or wherever we are talking about resources, but we really just want to thank God for the opportunity to have, even now as we speak, as an institution, the task force keeps track of our capabilities and resources that are available. And right now, touch wood, we still have at least over 6 months supply. And I'll tell you, some of it has been through the innovation of Kenya as a whole. The training of teams and what we were using for training was endorsed. So there's a lot of training, as the previous presenters have shown. This has worked. It's everywhere. It's online. It's demonstrations. This has been a great opportunity for us to impart knowledge. Teleconsultations, as you've heard, nothing new, but we reintroduced it in a different way. As you've heard, there was challenges. Suddenly there were no volumes. Suddenly patients were not coming. And at the same time, we needed to keep afloat. This was even before we got the first 2 or 3 patients. So it was like the place went quiet, standards had to be maintained the same way, we were still the same hospital, but there were no people coming in through. So teleconsultation started off, and I think the enhancement here is that certain insurances who had never accepted a teleconsultation as a fee to be paying for, suddenly endorsed it. And this has been great because the task force through their networks have been able to work with insurances for that. Our helpline, as you've heard MP Shah did, we also did it. In addition, we had frequently asked questions set up so that before you could even call the helpline, certain questions are kept on coming so that there is the correct literature out there. It was put up so people would easily get information that was accurate. That in itself, quite honestly, influenced the above teleconsultation. Why? Because when people began to call, within a short time, we realized it became very technical. So the calls were not, what's a mask? How long should I wear it? Or how do you hand wash? It was, okay, I have a baby. This is what the baby is experiencing. What should I do? And therefore, it led to the teleconsultation initially, because we are a teaching university hospital. So we have residents, we have full-time faculty and non-faculty who are available to pick the phone calls, and therefore our triage suddenly became 2 specialties and suddenly to teleconsultation. So really that's how the platform has grown. Of course, as you've heard, every hospital, and hopefully at least ours, dedicated an isolation unit outside the critical care unit, because initially it was, if those are the numbers we are seeing, if we get overwhelmed, critical care was still one of the units that we couldn't replicate almost immediately, but the isolation unit for patients who are not really requiring ventilation was set up. Further, as an institution, for those who are online and know us, we have an adjacent field hospital, which has about 100 beds, and thanks to the same task force, that has gone very well. It's a place where stakeholders have come to view. They have reported it as one of the few best ones that they have seen around here. So we are very, very grateful. We have a field hospital with 100 beds and can double up if ever the surge is there. We pray that it doesn't come, but if it does, that's what we've done. In addition, as you've had, information was weekly now. We started posters, we started weekly updates, we have online, we have put up social media updates, and this has been ongoing, and it's available for everyone on our website. We further introduced a weekly session for staff and faculty. Within a short time, you would hear different people asking, and we said as a task force, let us allow staffs and faculty to ask us the questions directly. So that task force, we created a weekly session. It's still ongoing even as we speak, and there are always many questions that come along. Staffs and faculty were further provided with masks. Each individual who works here, we are over 3,500, considering we are both a university as well as a hospital, incorporating everybody, frontline workers, receptionists, our housekeeping staff, our security guards. We gave every single person 4 pairs of masks and hand sanitizers, which are refillable. They can carry them in their pockets, and a thermometer. As you know, that was one of the ways everyone was told you must always know what your temperature is and all that. In addition, the task force was able to give innovation, and here we are. We are now producing our own hand sanitizers from our pharmacy. We don't have to pay as much to buy from the existing world. We were importing, by the way, before. You all know Anus Gel, and it was an import, and suddenly Kenyans produced, and in addition now we are producing our own in pharmacy. In addition, the task force, as you've had, medication to doorsteps is nothing new, but it was enhanced and it has gone on very, very well. Online staff and faculty questionnaire was introduced. Our sister hospital in Karachi, I must say, had given us this because they had an influx of patients much earlier than we did. And they said one of the things that helped them is a proactive questionnaire on a daily basis that comes up to everybody's phone, or for that matter, computer, where you answer 5 or 6 questions. It gives you a green light. You get a highlight as a tick to come in. You get a red, it means you can't come in, but you immediately are triggered to the occupational health team that you are someone who needs either to be reached out to or for you to come in for further review. And therefore then you're able to be screened and thereafter quarantine or otherwise. In addition to this, the task force is the one which is looking on all studies that are coming as requests. As you are aware, being who you are as an institution, the requests will come, everyone wants to participate and join. So this is a team that's looking very, very carefully of the requirements of the clinicians themselves and the studies that are being asked for from out there in the stakeholders. We are the liaison, task force is the liaison between government agencies and stakeholders. It is something that we look forward to more public-private partnership. There's a bit of that, but it's something that we want to leverage in and continue to enhance. Our country, as being a private institution, does not mean we are in a silo, and that's something that we are looking forward to continuing to do. Working from home guidelines were shared. This was a bit of a problem for us, and I will tell you, mainly because of financial issues. People thought, I mean, if you work from home, will my pay be cut and so on? It wasn't an option for certain people, and so on and so forth. There have been challenges on it, but there are guidelines that we have shared. That slide tells you there's something that we said as an operational committee, and this was the second committee that really was, I would say, the doers, the hands-on people. This committee, as it says there, never doubt that a small group of committed citizens can change the world. It's the only thing that does. This is the committee that has really changed everything. It's the implementation team, it's the evaluation team, it's the audit team, and it's the one that is primarily the bridge between the task force team and the ground team. There's been a lot of work that's been ongoing. It's draining sometimes. It came with a lot of, this is the team that argues the most actually, saying this is what the people are saying on the ground. They don't think this is right. And they just think you're handing over this problem to us. And then this operation team has to think through what the task force has requested as direction versus how to implement it and putting the teams together. This is the team that did the surge drill. It was a very well done surge drill where we had external people as auditors. It went very well. We're able to anticipate if ever there was a surge, how best we would do. This involved everybody from security to housekeeping to catering to the front line, of course, to visitors. As you've had, we had already restricted visitors, but we allowed during the drill certain visitors to come and behave the way they would if we got overwhelmed. And it was interesting to see the gaps that we would have heard. Again, because we already a Joint Commission accredited hospitals, drills are not new to us, but the way we do drills matters depending on what you have at hand. And this time being COVID, it was something to learn from. Further after that, we did departmental ones where we had continue to do endoscopy as a zone. What would you do, especially where airways are a big issue? We did with theaters, and with the theaters, of course, with the different teams, anesthetists, obstetricians, surgeons, different times of the day, some are evening, some are morning, just to see how we would work it out if truly there was a surge at the same time. One of the patients was COVID positive, yet required you to go into a theater for an emergency. How would you do it? And so those drills have been very, very helpful, and the feedback therein. I must tell you this. This is one of the places where our resources were tested, because certain times you had to don and doff as if this patient was there, and yet it's resources that are limited. So that's where innovation came in, and how we best did it was based in a lot of goodwill, and we had enough resources to continuously do this drill. So we are really, really grateful to our teams and our stakeholders who supported us on this. The guidelines, of course, have been implemented, and they evolve every day. Like I said, that's one of the places where there are a lot of arguments, because guidelines almost daily. COVID testing tests for all admissions was started. Why? As I started in the front one, is safety was priority and quality is a standard. So we knew for us to work this thing out, people must feel safe. So that's why we started the COVID testing for all our admissions. Currently, it's free thanks to the task force direction. Of course, as I said, the CEO is there, so we are testing every patient that comes in, just so that our clinicians also feel safe, and that there's something, and for our patients as well, to feel that that is important for them. I must tell you, just by screening admissions, we've had 2 or 3 diagnosed in a lot of 40 admissions, perhaps. Sometimes you just get 1, and some days there are more. So this screening has also helped us because asymptomatic patients have come up. So finally,
thank you.
Well, let me just finish this one, last one. The announcements of PA systems and all that has been ongoing, but I want to just bring this up because this is one of my last ones. The risk matrix behind it has helped us mitigate some of these risks that some have materialized, others haven't. And that aspect in itself has helped us care for our patients better, even as the patients keep coming back. This has been a big issue for us, and I just thought this one I would miss to let you know about psychosocial subcommittee. This was brought up after our first few patients came, the hotline, the way you can support staff, the seminars that have been happening, but most of all, the fact that you feel supported. At any given time, you're able to call in, you're told to stay home, and then there's someone else following you. So this has been very grateful, very, very well received by us, and it has helped allay the fears of losing our jobs or whatever, but that there's someone who cares for us, including in our cafeterias. This is another committee that obviously is looking at publications, and really those have been the learnings for us, and it is something that we hope.
You just leave the learnings up there as we move into questions. Would you just leave those learnings?
Actually, that was my last slide. Thank you.
Great. Well, thank you very much indeed for that. Intensely practical, meeting needs, evaluating risk. I thought the points you made about the importance of a proactive approach. So you've got the structures in place both for governance, but also for implementation and evaluation, and you're keeping ahead of the curve in that respect. Some very important learnings there, and I think we will want to explore them in the 15 minutes we have left for questions and discussion. So let's begin with any points that arise from any of our participants. Don't feel you've got to ask a question if you've got a point that you want to make. This is about sharing experience and good practice, what works, what doesn't. So let's have a look and see what's coming up on the chat. And there's a question immediately out there to director to Eunice. What is the current state of the statistics on the number of cases your hospital has had to manage? How many have proved to be tested positive? How are you deaths? I mean, give us some sense of the scale of the operation. Eunice?
So one of the things is we've not had a surge. We've had over 50 patients we've taken care of. Yes, we've had mortality at the beginning. When we first got a few patients, they were with comorbids, but I will tell you the number of cases that have recovered is what is more, and we are very, very grateful. So we've had loads of numbers. Over 50 patients have been through our hands and out of the hospital.
Thank you very much indeed for that. Any other questions or points that people want?
A question from Nasibu. I wonder how widely simulations or drills are being carried out in facilities in Africa. I don't know, Eunice and Tosif, you might have a view on that.
Tosif, why don't we begin with you?
Sure. I think as far as drills are concerned, I would only be in a position for now to speak about my hospital. And we have mass casualty incident drills, we have fire drills, and we also had, I would like to call it a dry run for receiving and discharging COVID patients. So they do happen as per our protocols every quarter. And if need be, where we feel we really need to, tighten a couple of things, then we do them a bit more often.
Thank you, Tosif. Eunice, how are you approaching this?
So just as Dr. Dean has said, I think speaking only for my hospital as a requirement, that already happens. But as a nation, I wouldn't be able to speak for it, but it's something that is good to have even beyond COVID,
Great.
Good. I wonder if I could address this to you all, actually, but to what, because I sense that Kenya is ahead of the field to a certain extent, in the extent to which it's got a highly developed private and philanthropic sector and a very engaged ministry. So that can't be said for every African country. I mean, Dr. Patel reminded us about the importance always of recognizing these different situations across the continent into which we speak. So I wonder if you'd like to share your experience of just how important that link with government and the opportunities for you to share with each other. How important has that been? Dr. Wanjeri.
Thank you, Paul, for the question. And I think public-private partnerships are important. So based on my experience, I've looked at it at different levels. So you find particularly corporate bodies coming in at the primary level where preventive measures, hand hygiene, nutritional supplementation. But when it comes to secondary and tertiary care, we see more or less our referral systems, where from government, we can refer to private. Hardly can we refer the other way around because the issues of cost come into play, So, but as time goes by, we see particularly on linkages in the various health systems, like particularly on the financing issue, there have been measures trying to see how public-private partnerships would work to make the cost of healthcare affordable. It hasn't worked very well to this point, but it's an ongoing process. The issue of workforce, we can see that there haven't been a balance yet. But progressively, we come to see at the primary level, the partnerships are working well, where I find corporate bodies, particularly with the county governments, they're working towards preventing diseases rather than treatment.
Dr. Patel, you're muted. Come off mute.
Sorry, I think, apologies. I think it comes back to something I touched on earlier, in that if a system is not geared towards universal health coverage, or you have a national system in place, hospitals, in terms of drills, simulations, protocols, and so on, can act very independently. And therefore, you do not get necessarily unified response. And a very good example, which we all need to learn from that, is typical if you look at the United States, where every hospital has its own policies and guidelines with no national implementation in place, and they're legally not obliged to fulfill that in terms of frontline health work management, but also in terms of training. So there needs to be a much more unified response. And that's something that has to come from the policymakers, but at the same time, health workers, I'll be the first to say it as a doctor, we are incredibly poor advocates for ourselves. And we need to be better at making our voices being heard. And once that is heard, especially now, this is the time in the peak of the pandemic, before the surge comes in the likes of Kenya and other countries in Africa, the voices need to be heard now. And that's the only way that you're going to be able to address these points.
And are they being heard? Is there a dialogue with the Health Committee in Parliament and at the different levels of local government? Do you speak into those?
I do. I think it depends on, like I said, depends from country to country. It really does vary. And I touched on DRC because we've worked. I personally have worked in Malungo in DRC in regards to this. And one of the biggest challenges you face is that everyone's expecting the WHO or WHO Afro in this case, or WHO EMRO in the Eastern Mediterranean region to come up with the answers or to come up with the guidelines. And that's very much typically a political view rather than necessarily a healthcare view. And we have to challenge that. And so we're trying to, and you're seeing some good progress. And that's why you will always see some countries doing better than others. But as I said, that's also a weakness. We cannot compare because every country is different. And that's also a weakness in itself. So we have to be very careful with that.
And Dr. Din, your experience of partnership working and how one initiates partnerships. Dr. Din, Tasif.
Sorry, Paul, about that. Please, could you repeat that again?
Yeah. What's your experience of partnerships between yourself, other hospitals, philanthropic organizations, the different levels of government? How's that working? And what works to make the partnership work?
Sure. I think we as a private hospital are actually following a lot of guidelines that have been issued by our Ministry of Health and our government. And I think they're doing a fantastic job in terms of, providing the right guidance. I know, like Kenya, many other countries do not really have a roadmap of where we are really going. We strongly believe COVID-19 is a marathon, and we really don't know how many kilometers we really have to run further. And every day is a new learning experience for us. So we keep running, and then we even run back sometimes. But the idea is to run forward, to be able to collaborate with the ministry, and they have been extremely supportive. We as a private hospital have been trying to do some testing, but unfortunately that hasn't worked for us due to some technical hitches, and they have been immensely supportive to us because we've been sending our samples to them. And with the turnaround time for about 24 hours, I think they've been exceptional. I know that they're also struggling because this is something equally new for them. As far as our donors are concerned, locally and internationally, I think the support has been immense. We've been donated quite a number of PPEs and a lot of other support that has also been rendered to us in kind, and we are thankful for that. I think it's the way you approach and how warm you are in accepting that kind of support. We have received support for things that we actually don't require, and we've been quite polite enough to be able to decline because, certain things, they just don't apply to our sector. So there is no need to collaborate with those sectors at this time. It's better we concentrate with what we do best, and that's what we've done over the last couple of months. Well,
in Kenya, you run very well. You run better than football. I would say that,
Indeed,
I'm a supporter and I'm from Ghana, so of course I prefer football to running, but there you are. Director Eunice, give us your sense. What can government itself learn? And we're not now talking specifically necessarily in relation to Kenya, but generally, what can the state sector learn from the private sector? And how do you how do you communicate with each other?
Interestingly, as you've heard, we've had great support from the government. It's amazing. But most of all, they've allowed us on the table. We are allowed to sit in their committees. We have representatives within the private sector. They have been listening to us from a private sector of health and other industries, for example, the innovations, for example, and that's part of the question that I'm seeing on public-private partnership, where innovation within AKU was about having an ultraviolet kind of robot that can do certain things. And before we knew it, this discussion was with government, and they are looking into how we can roll this out, because otherwise we would have been importing. As you've heard in the news, certain university students came up with ventilators and ways they can. So there is a lot of discussions, both with public and with private, and we are on the table, we sit in committees, and we're able to influence what is best and raise the standards of healthcare in this country. I
think that's a very important lesson for us all, to make sure you've got the right people around the table. And in coping with the pandemic, that means people from the public and the private sector, from the voluntary, for the for-profit, for the not-for-profit. I think it's an important lesson. Right, well, Nicole, have we got any further questions coming in?
Sorry, if I can jump in, Nicole.
Nick.
Yes.
Yeah, I'd just like to go back to an earlier request we had on the chat from Tony Winfield, if you'd like to respond. And then after that, I'd like to invite Zola Pato to make a couple of remarks as well, if I may.
Good, thank you very much. Tony, over to you. Unmute yourself. Great.
Right, you've got me on video. Hello, and good to see you again, Paul. It's been a couple of years since we were at Planet Earth. I'll try not to take long over this. I'm very interested in what Dr. Patel was saying on the point about education in general. I was writing vigorously as he spoke, and there were many things, many boxes that were ticked by what he was trying to achieve, problems, challenges that he's identified. I just wanted to start the ball rolling, what I hope will be a conversation I will have with Dr. Patel and others at a later stage. I've been working for the last several years on healthcare and education programs, developing relationships, particularly with China, where I'm working with hospitals there and looking at their needs. Conversations have moved on to training, emulating practices in the NHS. And I'm working with one hospital in Ningbo, just south of Shanghai, which is where Nottingham University is their twin city. And we're looking at many things. I'm working on both ends of the discussion. I'm working with the University of Derby, and we are looking at using the Clinical Skills Training Centre, which is for training up nurses, who ultimately, many of them go to the Derby Royal Hospital, where there's an equivalent centre there. Nottingham University, in partnership with them, the Queen's Medical Centre and so on. So there are hospitals involved, there are government involved, local governments and so forth. And there is a universal recognition amongst all of those partners that we can make progress in linking up less resourced countries with resources in the UK, a long history of good practice. And just to add one little background piece of information, I used to be practice and fund holding manager of the UK's first fully computerized medical centre. And that experience was instrumental in me exploring this through Planet Earth Institute and looking at things there, and my visits to Africa as well, meeting with ministers of health and so forth. I could speak more, and I don't want to because I don't want to take the time. But as I say, there are many elements of what Dr. Patel said in terms of bringing professionals together, collaboration, primary healthcare, which I have experience in. Certainly the technologies are a given. I and my colleagues and the universities are well versed in using appropriate technologies for this. But it can be used for large and small groups and so forth. But there are many advantages to that education. I look forward to hearing more from Dr. Patel and others on what the specific needs are and what challenges I can explore.
Thank you very much indeed, Anthony. And already coming up on the chat, a query from Nasibu. How can we collaborate, Anthony? How can we get in touch? So this is just the start of a conversation. Thank you very much.
It is. Certainly, Nick has all my details.
Great, thank you.
Thank you.
Zola Petro, how are you? Welcome.
Yes, I'm fine, thanks. How are you?
Good, very well.
All right, may I go ahead?
Yes, please do.
All right, greetings to everybody who is watching right now. I'm Zola from South Africa. I am the chairman and the founder of Tecmal Petroleum Services. So it has been so nice to listen to all the medical side of solutions happening. So basically from our side, we've got some engineering view of this, and all we are about is to try and bring the solutions that are already there so that they come in a simplified way. So this is one of the solutions that we have invented, and we have taken liberty to patent it here in South Africa and around the globe. So basically what it does is it is to bring a sanitizer around all the surfaces where the people are, because eventually all that happens is that people that have got an infection, they touch surfaces and others touch the same surface, and then that's how the whole thing spreads. So we basically supply a solution that brings at a click of a button or at an automated system, a sanitizer. Let me share a screen just to show something. It's a clip. I won't show what I wanted to show. I will show just something that will be very small, so that you are able to have an appreciation. So I've got a full clip on this. I've got a full presentation on this, but basically this is in an aeroplane. So in an aeroplane, we would really sanitize everything by a click of a button on somebody somewhere in front. Basically, this is how it would go. This happens in schools. This happens in offices. It happens in hospitals, everywhere. So we just basically release a sanitizer where it needs to be released, or on the places that are much more risky for or where there's a common use of different. I don't know if everybody saw that, but there's a whole lot of clips that we have packaged nicely. But I thought for the interest of time, let me show you that small one. So that's basically who we are. We are on the website Tecmal Petroleum Services, and we are also on Facebook. So there's much more of those solutions that we are having, just to bring the technology to make the sanitization possible and remove it from remove human error in it. Because if you ask people to wipe the desk and all those things, they are likely to forget. We do also have the thermal solutions, whereby we're able to, while you walk in a hospital, in a school, or wherever, we put a booth that is equipped with a access control. When you come in, it's able to read your temperature. It's able to you're able to answer all those cardinal questionnaires by them coming up and just say yes, no, and all of that. Then it records that data. Then in that way, you've got a data capturing system to make sure that those papers are not a bunch of papers somewhere at the end of the day. They are in a controlled space. So when you come in, you are screened in terms of temperature. You've answered the questions and you've not written any piece of paper. So basically, that's how our systems have been designed. Those are about a week-old solutions that we've come up with. We are in the verge of introducing them into the market. We have started introducing to our government, who are very excited to receive those. So basically, that's what we have.
Thank you very much indeed for that. And for that, practical example of innovative thinking that comes out of this crisis and of maximizing the intellectual property value that does exist on the continent. And we do need to seize this opportunity in order to get these solutions out there and to ensure that we add value and gain value for the continent as a result. So thank you for that. And I hope in the course of this series of webinars, and indeed when people view them thereafter, that this will spark added activity in this area. Well, we must now begin to draw this fascinating discussion to a close. I'm going to give all our contributors one last opportunity to make a final contribution. Limit it, if you would please, to a minute. Just a thought you want to leave us to take away with, either that's been either in response to something else you've heard or anything, just something for us to take away and to think about and to deliver on. Beginning, if I with you, the director, you. Nicole.
Sorry to interrupt, but if I may, we've had one more question from a viewer that I promised I'd read out, so I want to hold on to my promise. So very quickly from Dr. Wachira, she's asked that, said, thank you for the great insights and speakers, but the current modelling by the Kenyan government projects a peak in September, October with 6,000 severe cases requiring intensive care. So how can we prepare for this, bearing in mind that Kenya has about 500 beds for intensive care? So I'd like to take the liberty of directing that towards Dr. Din and Director Eunice.
Okay, Dr. Din and Director Eunice, would you like just to rapidly respond to that?
Dr. Din, are you on, or should I speak?
No, I'm very much on. I was trying to absorb the question. I think the closing remarks is firstly to thank everyone, Paul, Kunal, everyone who has contributed to this deliberations. And I think I'm very happy to be part of these deliberations. I myself have learned quite a number of things, and I'm going to implement a couple of two from Eunice's slides. So Eunice, I will steal a couple of points from you and collaborate with you more often. It's a pity that we work very close to each other and we've not really physically met one-on-one. So we do hope that we're going to have future collaborations with yourself and the rest of the team. I think at this moment in time, as I said in my presentation, spiritual nourishment is very important. We're keeping it for the last. And I think keep praying to God, be positive. And I think for us, let's deal with the whole COVID crisis with truth and science and not with rumor and panic.
Very important point. I wonder if I could press you a bit on the last question we had, which you may not have heard, which was relayed by Nicole, that the Kenyan government anticipates that the worst of the crisis, the peak, will occur sometime in September. And overall, there are only, 500 intensive care beds. So how do you see us planning, how do you see yourselves planning to meet that crisis, the eye of the storm when you come into it?
Well, there have been talks about shared ventilators, etc. However, I was reading some papers recently from the American Academy that they do not advocate for using shared ventilators. Unfortunately, Paul, this is going to be a decision where, we have to involve a standards and ethics committee to see who needs the care the most. Unfortunately, it's not a decision that's got a clear-cut answers, unfortunately. And it's true that those are the limited number of beds that we have available. And from those beds, there are beds that are already occupied by patients who are not COVID positive patients. So from 500 beds, I'm sure about 40% are already occupied. So we have to work with what we already have. And I think it's going to be a very ethical matter. And the team of doctors and nurses who are the primary caregivers of this patient need to make decisions, unfortunately.
Thank you very much for that response. I think that is a response actually that everybody will give, and indeed ought to give. But Nick, there's something for you and Nicole to take away there, because in the very first of these webinars, we did have a very interesting presentation on non-invasive forms of oxygen enhancement and the availability of relatively simple and accessible technology in meeting those needs. And I think it's very important that that sort of knowledge is shared. And you might want to make sure, I'm sure you are making sure, that that's fed into the picture, because the reality is that there is no way that this long-standing deficit in intensive care beds can be made up in a matter of months. It just is not going to happen. That's the reality.
Yes.
And I think Eunice has some interesting views on that, because I know
Yeah.
she was on that webinar, and I think we spoke about the simple CPAP on that webinar, which Eunice, I think you can...
Yeah. Director Eunice, why don't we come to you? If you in your closing remarks will also address that question.
So yeah, I couldn't agree more with Dr. Dean in terms of an ethical dilemma when it comes to sharing of ventilators and how to choose as we've seen the world go. But most of all, as you said, in terms of the CPAP that is non-invasive, used in the healthcare institutions, but at what level was an amazing phenomenal. And I think it's something we can explore. We would need it. It's the best way to go. I know the government has brought in a few more ventilators, but that won't resolve if we get such a surge. It is in relation to CPAP, and we cannot wait to collaborate on getting such equipment, which is, from a resource perspective, affordable, yet the impact will be amazing. Not just for COVID, even beyond, because our patients find it almost impossible to get into ICUs where, in terms of cost, where invasive CPAP is put, and it's only in limited ICUs, it's not all over the country. So that is something we can explore. And in closing that, and Dr. Dean, I look forward to meeting you in person as well. I know the other day more, but in closing, I think for me, just to take home is that if we don't lose sight of who we are and why we went into healthcare, and to care for people as we get cared for, I think we're going to be fine, and we can do this. That's my thought, and hearing everyone speak, I think we can do this. As you know, innovation, as we say, when there is need, people innovate. I've already seen it, collaborating together. I think we're going to do this and together, and putting God first, yes, indeed, is something that will make us move forward. And I think we'll work it through. We'll work it through. And thank you to everyone.
Thank you very much indeed. Dr. Patel, Kunal, any final thought?
Yeah, thanks, Paul. I mean, just to be brief as possible, as a clinician as well as someone who's working in collaborative education, of course, the first thing I would say is we've got to collaborate and continue to collaborate as we have done today. However, the other thing you always teach our students is not to always look to the future for something new, but always look to the past as well. And the continent of Africa and other countries and regions in the world are in a very unique position in terms of their learnings from other diseases and disease outbreaks. Very quickly, HIV has reached pandemic levels, yet we still refer to it as a global epidemic, bizarrely. And the learnings in terms of public-private partnership, in terms of collaboration, in terms of learning, in terms of health worker support, has all been developed within the HIV sector for many, many years. And we need to learn from our past. And if anyone is interested, a very good nurse from Durban by the name of Sabbath Malambo was just interviewed today on the 26th of May, and she's 90 years old. And she talks about the similarities that she saw in Durban with HIV and AIDS when she was a struggling nurse compared to today. So we do need to look back as well as try not necessarily find something new all the time.
Thank you very much indeed for that. Dr. Wanjeri.
Thank you, Paul. I think mine is just to reiterate what my colleagues have said. Public-private partnerships will come in handy. But I want to look at the fact that we have time, or rather we don't have time, but we have it. We have about 3 months as we anticipate the peak, yeah? I want to especially congratulate Aga Khan. They foresaw what was gonna happen, they prepared. If we take these 3 months, go back to the primary level, we're doing curfews, we're doing masks, but is that enough prevention? Is that enough that we're doing as a government to make sure that our people are not getting more sick? So unfortunately, when it comes to that time, unfortunately, especially for those of us on the ground, we might have to make those difficult decisions. Who lives, who doesn't, unfortunately. But I still feel in the 3 months, we have time. We have time to change a lot. We have time to make decisions. We have time to strategize. We have time to explore all the innovations. I agree with Kunal because of the fact that we have very short time. Let's use locally available things, create and innovate to actually curb this crisis. And as a parting shot, I'd like to say thank you. The conversation is healthy. the conversation is engaging. I think all this will come in handy in the near future, not just now. Thank you.
Thank you very much indeed for that. The important points that have been made, the importance of using this time for preparation, and what we are seeing with the whole delivery of this COVID-19 exchange set of webinars, and the participation of you all as speakers and as active participants, that we are seeking to make the best use of this time. And we'll be coming next week for the fourth and final event in this series to look at pandemics and premiums, financing COVID-19 treatment and recovery. We have an opportunity to use the time we have, long or short, to prepare, and to prepare on the basis of evidence, of shared conversation, to prepare also in a way that gets out there the sort of practical experience and home-built solutions that you have all been sharing so effectively in the course of this webinar. So a big thank you to our speakers, to you all for participating. Spreading calm, not chaos. Spreading calm, not chaos. Stay well.
Thank you, Paul. Thank you too.
Indeed. Goodbye.
Thank you very much. Thank you. Bye-bye.
Bye-bye.
Bye, thanks.